Hi, everyone. It's great to be able to virtually share this with you. And I would like to thank Myeloma Crowd and Dr. Ravi Vich for the kind invitation to discuss personalized therapy in myeloma with you. A lot of what I will discuss will build upon what Dr. Vij and Dr. Kumar have already shared. And you'll start to see that we're all looking at 2 or 3 very common themes that we think will come to fruition in the next 5 to 10 years for personalized therapy. So personalized treatment today, as has been alluded multiple times in the talks before me, takes into account 3 main factors. One is patient fitness and health issues. Second is, what are the characteristics of the disease? Is it high risk? Is it low risk? Are there certain mutations? And then what previous treatment have patients had before that? When we look at patient fitness and health issues, so by fitness, I do not mean just the age that's there based on your date of birth. I mean physiologic age. How strong is somebody? And we talk about the concept of fitness versus frailty. Now, sometimes a 70-year-old may be fitter than a 50-year-old, as I will show you in an example. And then we look at other health issues, including illnesses that can affect the heart, lung, kidney, and liver, or other issues which might affect how patients are able to tolerate drugs and if they might have more than expected side effects with certain drugs. When we look at disease and response characteristics, there are certain ones which we are commonly using in 2021. They include cytogenetic risk of myeloma by FISH testing on bone marrow, extramedullary disease, which is presence of disease outside of the bone. So for example, in soft tissues, and we find that by imaging, such as with PET scans or CT scans. Circulating plasma cells, if they're seen in the blood, are a marker of high-risk disease, and we tend to treat those patients more aggressively. And then once we start treatment, we use M protein or serum-free light chains based on blood test to tailor treatment. If things are working well, we might just continue same course. If things are not going well, we might change therapy. But I think there are several ones which are the wave of the future. And this has been mentioned by Dr. Vij and Dr. Kumar. One is testing and treatment based on minimal residual disease. And I will come to that in the latter part of this talk. And then guiding treatment based on specific cytogenetic abnormalities and specific mutations in the myeloma itself. And then maybe using in vitro drug sensitivity testing to see if a particular drug might work for a particular patient. So I wanted to give you some examples. These are 4 patients that I saw in the last week in my clinic. And as you would see here, there are certain factors based on patients' age, fitness, and their risk that made us make different treatment decisions. So for example, I focus your attention on the left-hand side to patient 1 and 2. Both of these patients were in their 30s, didn't really have any other medical issues. And this is an atypical age to be diagnosed with myeloma, but we do see patients who are very young diagnosed with myeloma sometimes. Patient 1 had high-risk disease with presence of deletion 17p and translocation 414. And so presence of 2 mutations make the disease very high risk. Patient 2 had standard risk disease with presence of just trisomies. So for patient 1, when I saw them in clinic, this patient was on 4-drug induction regimen with daratumumab, bortezomib, lenalidomide, and dexamethasone. And we were talking about next steps. So we talked about a tandem transplant, which is 2 back-to-back transplants. We also talked about an allogeneic transplant for this very young patient, but decided that we'll use that when the disease comes back if that's necessary. And so this patient is getting a tandem transplant. And because of their high risk, we will put them on at least 2 drug maintenance with both lenalidomide and bortezomib. In comparison, patient 2 has standard risk disease. And so this patient received only 3 drug induction with bortezomib, lenalidomide, and dexamethasone. We do know that transplant leads to better outcomes, both for progression-free survival and deeper response rates. So we did recommend transplant for this patient, even though this patient was in a complete response. But for maintenance going forward, we'll only use single drug maintenance with lenalidomide. When I look at then other patients, so patient 3 and 4, patient 3 was a patient in their 50s, but this patient had significant heart and lung illnesses. They had reduced pumping capacity of the heart. They had reduced capacity to exchange air with their lung. And even though this patient is very high risk, and we know transplant benefits this patient population much more so than maybe even standard risk, we had a one-on-one conversation stating that the risk with transplant and the complications with transplant in this case probably would be very high, and we should not take that risk. So we just collected stem cells with hope in the future, if these things improve, we can transplant later on. But at this time, just decided after 4-drug induction regimen to continue lenalidomide and bortezomib as maintenance therapy. When we look at patient 4, this patient is in his 70s. And while there are some medical issues like high blood pressure and some other minor issues, they're very well controlled. So despite being almost 2 decades older, because of the medical issues, this patient was thought to be a candidate for transplant. And after receiving induction therapy with bortezomib, lenalidomide, and dexamethasone, we decided to move forward with transplant. And for maintenance, we'll just use single drug maintenance with lenalidomide. And so this is just patient in the past week. And as you can see here, even these basic characteristics, such as patient fitness and risk and other illnesses, can help us stratify patients into different treatment paradigms. And as Dr. Kumar mentioned, maybe this is not true personalized therapy, but this is at least therapy stratified by personalized risk factors. So what about relapse disease? And I want to share with you an example of a patient of mine who had relapse disease where we used personalized medicine to make treatment decision making. So this is a 63-year-old patient with relapse myeloma who had received 4 prior lines of therapy. At the time of diagnosis several years ago, this patient had translocation 1114 on FISH testing in the bone marrow. So this patient went through all of the therapies we'd expect most patients who've had 4 lines of therapy to undergo. Got 3-drug induction, got a transplant, got lenalidomide maintenance. Then the disease progressed. It was progressing slowly, so this patient got elotuzumab, pomalidomide, and dexamethasone. At some time, the disease progressed again, and this patient got daratumumab, bortezomib, and dexamethasone. And finally, they got carfilzomib, cyclophosphamide, and dexamethasone, all drugs that many of you might have been on or may have heard your friends to be on. Finally, as the disease was progressing, it's very important to, at that time, repeat testing to see the extent of disease on imaging, and also repeat bone marrow testing. And we repeated FISH testing and saw that translocation 1114 is still present. Usually it's not common to lose this translocation, but sometimes clone sizes can increase or decrease. But sometimes you see other abnormalities add on as the disease progresses. So there were several treatment options I discussed with this patient. I discussed venetoclax, which has been brought up many times now. We discussed other options, including CAR T-cell therapy, because this happened recently and CAR T-cell therapy was FDA approved and clinical trials. This patient was leaning between venetoclax and CAR T-cell therapy. And as Dr. Witch mentioned earlier this morning, there is some limited availability of CAR T-cell slots at this time. And so the wait period was a little unpredictable. And therefore, for this patient, we decided to go forward with off-label venetoclax. As venetoclax is FDA approved for other cancers, we are able to use it. It also sometimes depends if a patient's insurance will reimburse it. Sometimes we can get it for compassionate use from the company. Again, this patient had a rapid response with venetoclax and dexamethasone, and this response is ongoing. And this drug is very well tolerated without any significant adverse effects in this particular patient. And so this is data from the venetoclax phase 3 trial, which combined it with bortezomib and dexamethasone. And on the left-hand side, you can see here that while venetoclax led to improved progression-free survival in all patients, it did not lead to improved progression-free overall survival in the entire cohort. But when we specifically look at the subgroup of patients with 1114, these patients had the most advantage of this drug. It led to significant improvement in progression-free survival, and there was no concern seen for overall survival as it was seen in the entire subgroup. So again, this is a good drug to use off-label when we don't have other treatment options for patients with relapse disease who have 1114. And we might also be able to use it in patients who have high expression of BCL2 when we test it by other methods. So sequencing of myeloma cells to look for mutations has also been brought up. And now we have technologies that can identify mutations at an in-depth level by sequencing both tumor DNA and RNA. And some mutations may be targetable in myeloma by drugs that are available to treat other cancers. These include mutations of the RAF and RAS genes, mutation of the IDH2 genes, and CDK mutations, amongst others. So this is a published case report of use of a BRAF inhibitor, vemurafenib, in combination with cobimetinib, which is a MEK inhibitor, in a patient who had this particular mutation called BRAF V600E. On the top panel, you see results before the treatment. The left-hand side, you can see this patient had a mass under their armpit. And on the panel below, you can see this mass disappeared with treatment. On the right-hand side panel, on the top side, you can see there was this dark mass under the armpit, which then disappeared with treatment. But there are several limitations of using this approach as just a trial and error once you see a one-off patient in clinic. We tend to do that sometimes when we are out of treatment options, but then it's very difficult to estimate, well, how effective is this in a group of patients? I cannot quote my patients, there's an X% chance you will respond if we'll find something for you. And I think it's very important to systematically study this and also to systematically address side effects. Does it lead to more side effects in myeloma patients than other patients for some particular reason? And I think in this setting, it's very important to have clinical trials that study these specific mutations. So this is the Burma trial that was brought up in the discussion session earlier today, which looks at patients who've relapsed after 2 prior lines of therapy and have the BRAF V600E or K mutation in more than 50% of myeloma cells. It's been already discussed. It's important to know in how many percent of myeloma cells that mutation exists, because it will only target that many proportion of cells. And so in this trial, this is early data presented at the ASH meeting in 2020, 10 out of the 12 patients responded to a BRAF and MEK inhibitor combination. So an overall response rate of 83%. It's too early to say how long these responses will last, and I look forward to seeing updated data from this trial in the future. Now, Dr. Kumar already described ongoing clinical trials of personalized medicine. I wanted to highlight the MyDrug trial, which uses having particular mutations and then combining that with the backbone to target myeloma therapy. Then moving on from specific mutations to using minimal residual disease testing. So we all know that the way we currently assess myeloma response using blood tests like mSpike or free light chains or even bone marrow testing routinely can only pick a certain amount of myeloma. There is much more amount of myeloma that's under the surface that these tests are just not sensitive enough to pick. We have now newer technologies to detect this minimal residual disease, which can still detect it at a much lower level. Again, these are not perfect. We're not detecting all of the disease, but these are much more sensitive than what we currently have routinely done. There are many tools to assess MRD negativity. This can include next generation flow cytometry testing, which requires a bone marrow sample. Next generation sequencing testing by clonoSEQ or other tests, which again requires a bone marrow sample. And so these are not possible to be done at multiple time points. We also do MRD testing based on PET scan results or other imaging results to see if there's any residual disease that's left over. But I think the future for these tests needs to be blood-based, so we can do them non-invasively and more frequently to monitor treatment outcomes. And so we very well know that getting to MRD negativity in groups of patients results in better outcomes. This is a meta-analysis of 14 studies that evaluated patients who were MRD negative versus MRD positive. And not surprisingly, patients who were MRD negative did better than patients who were MRD positive. So the current use of MRD testing based on the data we have to date is just information on prognosis and outcomes. If I do MRD testing, this can just tell my patient, based on historical data and groups of patients, this is what they can expect in general. But I think the future is, can we use MRD to make treatment decisions? We can escalate treatment if someone's MRD positive, or we can de-escalate treatment or stop treatment if someone's MRD negative. And it's hard to do this anecdotally again in clinic on a one-off patient. And we need to follow the results of several clinical trials that are ongoing for this purpose to see what are the outcomes of patients when we do this in a very systematic manner. So I'll share with you, example of a particular clinical trial, and there are several of them ongoing, both to escalate and de-escalate treatment. So this is the master trial. This was presented by Dr. Luciana Costa at the ASH meeting a couple of years ago, and also presented recently at the International Myeloma Workshop. And in this trial, patients who are fit get a very intense treatment upfront. They get 4-drug induction with daratumumab, carfilzomib, lenalidomide, and dexamethasone, and then undergo a transplant. And then they may get consolidation with this 4-drug regimen in the future, followed by maintenance. And in this, MRD is tested at various time points shown here. And once people are MRD negative 2 times consecutively, their treatment is stopped and they will go on to observation and surveillance. Again, results of this trial and similar trials would be very important for us to know in the next 2 or 3 years how MRD can help us decide treatment decisions for our patients. Again, Dr. Vij already brought up, can we use in vitro drug sensitivity assays? So this is outside of a patient's body. Can we test their myeloma to see which drugs they'll be sensitive to? And there are various techniques to use it. This is one using proteomics to test sensitivity to drugs. But there are limitations of these assays, as has been discussed, right? It doesn't test the whole tumor microenvironment, including the immune microenvironment, which plays a huge role in treatment outcomes and disease control. So this has some applicability. Hopefully we can have more, complex systems in the future, which can further help us with this. So in summary, personalized medicine in myeloma today includes assessing patient-related factors, myeloma-related factors, and treatment-related factors to make treatment decisions. We are very commonly using patient fitness and FISH testing and cytogenetic testing to make treatment decisions for patients. But I think there's several opportunities to improve personalized medicine, and all of these are being studied in clinical trials or other research studies, which specifically include MRD testing to guide treatment decisions, treatment based on specific mutations, and maybe one day in vitro drug sensitivity testing. With that, thank you very much for your attention.